Hello and welcome to the Rural Doctors Program. I'm Jerry Gannon. In this broadcast, we're going to be looking at different types of X-rays and imaging. Dr. Rodney Greenberger, Managing Partner at Perth Radiological Clinic, joins Dr. Olga Ward to discuss some different images and what they're telling you about your patient.
Welcome to the program, Rodney.
Thank you for having me.
Chest X-ray is very difficult for GPs to report, and sometimes the X-ray film is right there in front of you and you have to make a clinical decision based on it. But the professional reporting from the radiologist may take 24 hours or even longer for a country doctor. Could you talk us through how you look at a chest X-ray?
First thing is that chest X-rays and radiographs in general are really quite difficult to look at and interpret, and having a system will help. I've got a chest X-ray of probably a fairly typical patient which you might get a radiograph of, and the first thing is to have a look at the film and see if you think it's adequately penetrated. So you want to be able to see if you can see the thoracic spine reasonably through the mediastinum. Can you see the left hemidiaphragm? That looks pretty hazy. So it's not really very well penetrated. The other thing to look at would be to count the number of posterior ribs which are present, and it's nice to get down to about the 9th or 10th ribs.
So posterior ribs are these ones?
Yep, so you've got 1, 2, 3, 4, 5, 6, 7, 8, and then you lose it, so it's not a greatly inspired film, and what that's going to cause is all these markings down the bottom to be all clustered together, and it's going to be very hard to know whether the patient's got a pneumonia or whether it's just all the normal bronchovascular markings just being basically compacted together. Mm-hmm. So if we go to another chest X-ray, then suddenly you see, well, this is better inspired. You're getting 9 or 10 ribs posteriorly. You can see the thoracic spine reasonably through the cardiac silhouette. You can see the left hemidiaphragm this time nice and clearly. And it's much easier to interpret a chest X-ray which looks like that. The next thing to look at is to see if the patient's rotated. And the way we do that is to look at the spinous process of the thoracic spine and look at the medial aspects of the clavicles which are marked there, and just see if it's equidistant. If it's equidistant, then it's well centred. If it's not, then you're going to have problems interpreting the chest X-ray, because one lung will be darker, the other lung will be lighter, and then it becomes difficult to know what's going on.
So if the patient's quite kyphotic or a little bit twisted because of muscle spasm or something, you're going to get that same effect.
You're going to get that effect, and you may have to accept that. If it's a badly rotated film, you might want to repeat it or try and repeat it. The other thing to check as we go through is just to make sure that you know whether the film has been taken PA or AP.
Mm-hmm. How do you tell?
Well, there are markers usually on the films which will tell you. We've actually cut off names and so on this picture, but if you're not sure, you just ask the person who took it and say, well, was it taken with a patient supine, erect, AP, PA? But you need to know that, because if it's AP, you really can't assess heart size accurately. If it's PA, you can. You need to make sure the right and left markers are correctly placed. You may find the patient's got situs inversus, but usually it's just that they put the label on the wrong side. You need to just go and ask if there's any question about it. Usually it's mislabeling rather than the patient having an anomaly.
Now, in an emergency situation, often people take a supine chest X-ray. Can you tell anything from a supine chest X-ray?
Oh, you can tell quite a lot from a supine chest X-ray, but you just have to be cognizant that if you're looking for a pneumothorax, it's going to be very difficult to see. You're not going to find it in the usual location. Pleural effusions become very difficult to see because, again, they're not in the usual location. But if it's adequately penetrated, you'll be able to see if there's consolidation. You'll be able to see if there's any mediastinal shift, and you may have to take additional films. What's quite useful if the patient can't sit up is just to roll them onto one side or the other side and do a decubitus film. And if they've got a pneumothorax on one side that you're suspicious of, then you would lie them on the opposite side and put the side of the pneumothorax on the higher side, and you'll see it quite clearly. If you think they've got a large effusion or a hemothorax, then you do the opposite. That goes on the lower side, and you can see if there's fluid. So you can still get a lot of information from a supine film, but it is more challenging, and you may have to take some additional pictures.
When you're doing a PA film, can you get away with not doing a lateral?
I think in most patients you can get away with it, but you prefer to do a lateral because on the PA chest films you're going to lose the posterior basal segments of both the lower lobes. So if you've got pathology in the lower part of the lower lobes, you're going to miss that pathology. Yeah. So in most adults, unless it's a routine chest X-ray, we would do laterals. In children,
so that's because it's down behind this hemidiaphragm here.
So if you've got pathology down here or down here, you're going to miss that. So certainly in an adult, you'd want to do lateral chest films. In young children, we often only do an AP or a PA film, and often because of the build of children, you can actually still see through the diaphragms and have a reasonable view of what's going on at the lung bases. But even then, if you're concerned that there is a basal pneumonia, you would probably want to get a lateral film. Yep. In terms of how to look at a film, don't do what radiologists do. Radiologists don't have a system, we just tend to look at it. But if you're not used to looking at films all the time, you need to go through a... So the first thing I would do is to look at the mediastinum and look at the heart size, look at the trachea, see if there's any tracheal shift and any mass lesions. And then I would move out to the lungs and have a look at the lungs and see if there's any nodules, consolidation, infiltrates or anything of that nature. And then move out to the pleura, see if there's any pneumothorax, effusions, pleural calcifications or any other pleurally related pathology. I then move out to the rib cage and go through all the ribs and see if there is any rib pathology or rib fractures. And then move out to the soft tissues and look at the chest wall, see if there's been a mastectomy or anything else going on in relationship to the chest wall. After that, I go and look below the diaphragm. I make sure that the gas bubble is on the correct side. That will actually help you know that it is the left side of the film. If someone's mislabeled it incorrectly, it'll tell you if there's free gas beneath the diaphragm. You may see a hiatus hernia associated with that. So looking in the upper abdomen is certainly worthwhile. And then if the patient is in a situation where they've got nasogastric tubes or other tubes in or lines, then have a look at all the lines and make sure they're all satisfactorily placed. So I tend to start centrally and work out. Some other people would start at the periphery and work in.
Or the top and work down.
It doesn't really matter as long as you have a system. But, you know, the money is usually mediastinum, lung, pleura, and then there's lots of other stuff which occur as long as you remember to look at everything.
As a radiologist, what information is absolutely vital for you on a referral form?
Well, anything which we can get, we're always grateful for. I mean, the more information we get, the more specific our report will be. You know, if we have a patient who comes in with a chest X-ray with a history of cough, well, that really doesn't help very much. It can be almost anything. So if you know, the patient is febrile and we find consolidation, then we're going to be talking about pneumonias. If the patient's coming in with pleuritic chest pain and shortness of breath and we find some peripheral consolidation, we'll be talking about pulmonary embolism. You know, if the history is 1 week, it's going to offer a different differential than if it's 3 months. So, you know, is there a history of trauma related to it or no history of trauma? So it really helps us narrow down the differential diagnosis which we put out.
Rodney, the commonest scenario I think we would see as a GP is an older person with an increasing shortness of breath. Possibly they've just had a cold or a bit of a flu and clinically they've got a few creps and not much else. If there's an early pneumonia, will we see much on a chest X-ray?
By the time they present for a chest X-ray, usually if they have got a pneumonia, there should be findings. They may be subtle and difficult to see, and certainly if a chest X-ray doesn't demonstrate a pneumonia and you're suspicious, then we can go on and CT the patient. But generally speaking, we should see something on a chest X-ray if there is a significant pneumonia.
Yeah. And with those kind of more diffuse bronchopneumonias rather than a nice solid blob, what do you see on a chest X-ray? And How do you pick it from a poorly penetrated chest X-ray?
X-ray. Well, I guess you have to make sure that it's well penetrated and adequately inspired, but you will see patchy, fluffy areas of consolidation on a chest X-ray, peribronchial thickening. That's quite difficult to objectively assess, but once you get the more fluffy, patchy consolidation, then you've home and hosed in terms of a bronchopneumonia.
Mm-hmm. And what would give you a suspicion of there maybe being an underlying mass lesion if you had a localised pneumonia, say a bronchopneumonia?
I think if you've got a localised pneumonia, lobar pneumonia or a loss of volume with a collapse, on chest X-ray there are certain signs which we look for in terms of that. We're looking for an underlying central mass or pathologically enlarged lymph nodes which may go along with it. It may look somewhat nodular, the area of pneumonitis which is present, because often you can get a pneumonitis around an actual carcinoma. Very often it comes down to treating the patient for the pneumonia or suspected pneumonia for a couple of weeks and re-X-raying and just seeing what is left.
So what's the lag time between clinical resolution and radiological resolution?
Well, it varies quite a lot, but in younger patients we will often see things settle in 2 or 3 weeks. In the very elderly it may take 6 or 8 weeks to really get good resolution, but in terms of seeing if there is an associated malignancy present, you may get clues on the follow-up chest X-ray in that interim. So you may want to re-X-ray it in a few weeks. And
you said mediastinal lymph nodes.
Yes.
Can you just point out where those would come up, where we would see those?
So mediastinal nodes, the hilar nodes live around these areas where you see the pulmonary arteries and pulmonary veins draining, leaving and exiting the mediastinum, and then you'll often see paratracheal lymph nodes running up and down the adjacent to the trachea, and there's an azygos node which just lives there, which relates to the azygos vein.
Could we have a look at one of my patients? This is an 80-year-old lady with a lot of medical problems. She has reflux and osteoporosis and functional dysphonia, supposedly functional dysphonia, and recurrent abdominal wall pain. She's a very shallow breather because of the abdominal wall pain, and she presented with a chronic dry cough, but the feeling that she actually had stuff in there that she needed to bring up with nothing happening. She wasn't febrile and she didn't really look unwell, but totally exhausted from the coughing. And clinically, I think people thought it was a psychological problem rather than a physical problem. But could you talk us through her chest imaging and the sorts of things that you saw?
Sure. So this is the PA chest film which is being performed, and you can see in this particular case it's poorly inspired, but it's not because the patient hasn't taken or tried to take a deep breath, it's because the patient can't take a deep breath. So you would probably get a note coming through from the radiographer who took the X-ray saying, tried twice as deep a breath as possible, can't do better, and otherwise you can't tell.
Yep.
So if the patient just didn't try, it would look very similar. So in this case, you can see there is reduced lung volume, particularly on the right, less so on the left. There's elevation of the right hemidiaphragm relative to the left hemidiaphragm. You can see there are some linear band shadows running out into the right mid-zone, and you do get the impression that there is an element of peribronchial thickening. If we go on to the lateral chest film, you can again see the right hemidiaphragm is raised, and when you look particularly toward the posterior basal segments, there are just too many lung markings present to go out so peripherally, and the bronchi are just a bit too thickened.
This looks
thick
to me.
Yes.
Yeah.
So yes. So in that posterior basal segments, you can see that there is something going on down there. Now it's not actual consolidation. You don't see an air bronchogram at all, but there is a process going on, which, in the context of a chronic history of at least several months, you would start to be concerned that this could relate to some form of bronchiectasis or interstitial lung disease or some other chronic process on the chest X-ray. You can't take it any further on the chest X-ray. but you would be suggesting that someone who's got this appearance on a chest X-ray, that they require a CT to take it further. And that was proceeded to. I'll just run through a few images of the CT before I start, so that everyone can just have a look at what we're looking at. And you can see that there's been 2 runs on the CT. The second half of the CT has been performed with a patient prone, and the first run supine. And the reason why that is done is that obviously we're trying to improve the aeration of the lung bases by turning the patient prone. And any patient who we suspect may have some form of basal pathology or interstitial lung disease, we would always do prone images at the end of the normal CT examination. So if we start at the bottom of the screen, bottom of the slides and work our way up, you can see that there is a honeycomb effect in the posterior basal segments of both the right and left lower lobes. And that honeycombing is really quite advanced stages of interstitial lung disease. Now, I'm unaware whether the patient has got a known condition such as rheumatoid or other connective tissue disorder which may be associated with interstitial lung disease. The majority of times when we see people with actual honeycombing, it is due to UIP. But in association...
What's UIP for those who
yes,
don't use
usual interstitial pneumonitis, or what was previously termed as cryptogenic fibrosing alveolitis.
Yes, okay.
So one of the associated changes with chronic interstitial fibrosis is that you can see when you're looking at the bronchi in the lower lobes, if you find a bronchus and an accompanying vessel, they should be about the same size. But in this case, you can see the bronchi are much larger than any of the accompanying vessels. So the patient has got bronchiectasis.
So
and in this case...
This is the chronic dilation of bronchiectasis.
Yes.
Yeah.
But this is quite severe bronchiectasis, traction bronchiectasis in this case.
What do you mean by traction bronchiectasis?
Well, because this is associated with interstitial lung disease, the fibrosis is actually pulling it apart, versus primary bronchiectasis, which may have occurred because the patient may have had TB or pertussis or some other condition earlier in life which dilated the bronchi and damaged the bronchi. In this case, it's actually scarring and fibrosis which actually pulls the bronchi to be more dilated.
One of the things that we see as country doctors is elderly patients who are getting short of breath at night, and while we might think that they have COPD or asthma or a chronic infection, quite often what we're looking at is congestive cardiac failure and a bit of pulmonary edema. Could you maybe talk us through what we would see on a pulmonary edema X-ray?
Sure. So this is just a series of X-rays looking at patients in congestive cardiac failure. The first thing on the PHS film, making sure that it is a PHS film and not AP. Look at the heart size and see if there's enlargement. Is it greater than 50% of the normal cardiothoracic ratio? And when you look at the vessels, this is the early stages of congestive cardiac failure. You can see there's a vessel accompanying a bronchus, and in this case the vessel is larger than the bronchus, which would suggest that there is a dilatation of the pulmonary veins. After you get the dilated vessels, particularly dilated vessels going into the upper zones of the lung fields, is you start to look for these interstitial lines, and these are curly B lines, and it's just fluid which is accumulating in the interstitium. This is a CT of a patient with pulmonary edema, and you can see where normally the septal lines are almost imperceptible, you can see these thickened lines outlining the lobular septi within the lung field. You can get these interstitial lines with lots of other conditions, including infiltration with tumour, hemorrhage and so on. So, but in the correct clinical context, that would be edema.
Rodney, the other very stressful thing in a country emergency department is the trauma patient. This is one of my local farmers who, as you can see, has previously had some surgery on his clavicle, and he presented having had quite a severe car accident. He actually presented it a couple of days later saying, I'm really very short of breath and my shoulder is killing me. When I sent him down, this is what came back.
Looking at the chest X-ray, the first thing to note is the heart size is probably within normal limits. There's fluid at the lung base, which makes it difficult to see. One thing to look at initially is just look at the mediastinum and just make sure if he's been in an accident that there's no widening of the mediastinum, which might indicate that he's injured his thoracic aorta, and there's no suggestion of abnormal widening. As you go out through the lung fields, you can see that there is some loss of volume on the left as compared to the right, and
I can see something that looks like a great big rib fracture as well, in the middle there, or two, yes?
Yes, or three.
Here and here?
Yep.
Oh, and this one?
So there's fractures there and there, so there are several rib fractures. You can see the pleural surface running down through there, and so there is a pneumothorax present.
Okay, could you just re-point that out, because it's not enormously obvious?
So that's the margin
that's the edge of the
pleura,
lung there, yeah?
And obviously it should come up to the apex, and it doesn't, and it comes down to about there. And the other thing is that there's fluid there, so there is it could be a pleural effusion, but it's probably a hemothorax, you know, given that there's multiple rib fractures and a pneumothorax. So there is a hemopneumothorax present, and there's areas of atelectasis and collapse present toward the lung base. In this patient, the first thing to notice also is that there is no mediastinal shift, so it's not a tension pneumothorax. So that takes a little bit of the pressure off in terms of making a decision. If you could follow the pneumothorax down, and if you look toward the level, I guess, of the region of the hilum, if you have a pneumothorax which is roughly about 2 centimetres deep, it usually means that there's about 50% loss of volume of the lung. So normally you're talking 2 centimetres, so it would have to be circumferential going down.
So, yeah.
There are formulas you can use if you want to be scientific about
2 centimetres from the side and 50% loss of volume sounds pretty good to me.
And that tends to be the point at which people would start thinking about putting in a intercostal catheter or draining the pneumothorax.
Yeah. With this inspiration and expiration, what sort of differences do you see?
Generally speaking, we use expiratory films if there is a question of a pneumothorax, but it really only helps if it's a very shallow pneumothorax toward the lung apex, and you're just trying to accentuate it and make it bigger. If it's a more substantial pneumothorax, it doesn't make an awful lot of difference. You will see it quite clearly on the inspired and the expired films. And
I guess our last dilemma as country GPs is X-raying children. Quite difficult because, of course, a lot of the nurse radiographers aren't licensed to X-ray children, but assuming that we can get a paediatric chest X-ray, what sort of situations would you find that most useful?
Well, I think in any situation where you're concerned that there may be a pneumonia, younger children, bronchiolitis, if they've got severe asthma, which is difficult to control, and you're looking for the complications of asthma, which may be things like pneumothoraces and pneumomediastinum, I think all of those clinical situations would probably be worthwhile going on and doing a chest X-ray.
Okay, so here's a paediatric chest X-ray. What can you see on this child who presented with a chronic cough, or at least a cough of 3 weeks duration, perhaps, or 2 weeks duration? Very little kid. Yes, it's a young child. It was taken AP, as you can see, and it's only a single film. When you look at the lung fields, all the bronchovascular markings going out into the periphery are all a little bit prominent, and when you look at the individual bronchi end on, there is, so there's a bronchus there end on, you can see that it's thickened and cuffed, and so there is peribronchial inflammatory change and interstitial infiltrate that goes out into the lung fields. Yes, there is that as well, so on the right side of the chest film. And in a young patient of this age with these findings, the appearances would be very suggestive of bronchiolitis due to respiratory syncytial virus or other type of viral infections. Because it's fuzzy and diffuse, but
but
that looks like it must be quite a sick little kid.
Yes, but there's no actual pneumonic consolidation present. It's all basically peribronchial and interstitial type infection, and in these cases often it can actually be quite difficult clinically to hear very much when you're actually listening to the child.
just because they can't ventilate.
They can't ventilate well, and a lot of the signs which you hear on auscultation tends to be when there's consolidation rather than just interstitial infection. So that often is much more silent than the clinical findings with consolidation.
And we'll hold that discussion there for just a moment. Now, deciding what sort of imaging you'll need to order will vary from case to case, and sometimes it's just not possible to send a patient back and forth for different types of imagings. The Diagnostic Imaging Pathways has been developed as a clinical decision support tool and educational resource for diagnostic imaging. We spoke to the chief editor of the resource, clinical professor Richard Mendelson, about the information it can offer, and he takes us through some common pathways that may be helpful to you.
A dozen or so years ago, some colleagues and I realised that there was a need for imaging guidelines for general practitioners and junior medical doctors and others who referred for diagnostic imaging investigations. And the need for that was apparent because, first of all, it appeared to us that the technology was becoming more and more complex, and therefore the choices that referring doctors were faced with was more and more complicated. Also, it was apparent that there was quite a lot of inappropriate imaging. And by that I mean that some patients were getting imaging that didn't require imaging, others were getting the wrong type of imaging, and also, and much more difficult to quantify, some patients were not getting imaging who did require it. So we developed at that stage our application called Diagnostic Imaging Pathways. This is a decision support and educational tool which takes the form of flowcharts and try to educate the referring doctor as to which is the most appropriate imaging in particular clinical situations. Now, it's very important to note that these are guidelines only. They are only recommendations. They are based on evidence, the best evidence available. They're also based on consensus, but nevertheless, they are still guidelines, and ultimately, the decision as to whether and how to investigate patients is a matter between the individual doctor and his patient, his or her patient, in a particular clinical circumstance. The other thing I must say is that you will notice that in some areas the access by rural doctors may be limited, so some of the recommendations will not be necessarily appropriate to a rural practice where imaging modalities are relatively limited. We did actually think about, when we first did this, to actually do two websites, one for GPs, including remote GPs, and one for hospital doctors. But we decided in the end that one website using what we regarded as best practice flowcharts was the way to go. And I think that rural doctors, where imaging modalities are limited, should first of all consider if, for example, an MRI is the recommendation, should consider that a signal that there should be specialist referral, but also where CT, for example, is a viable alternative to MR, we do actually say so. So we do give alternatives. So Diagnostic Imaging Pathways is freely available on the internet on www.imagingpathways.health.wa.gov.au. You don't need a login, you don't need a subscription, and it's entirely free. This is the home page, and you'll see on the left here, this is all menu driven, and the main crux of the matter is under Imaging Pathways. Now, if I click on Imaging Pathways, you'll see that the pathways are actually organised by organ system, and I'm just going to pick one, neurological, which gives you a list of the clinical indications or the clinical scenarios, and you'll notice that many of these, or most of these, are expressed in terms of the way patients present. They're not necessarily expressed in terms of pathology. So I'm going to pick headache as an example. So if we click on headache, that takes us to the home page for that particular website. And on that home page, you'll see that it gives an overview of what the pathway hopes to achieve. It also tells you when that pathway was last modified and when it's next up for review. And we try to review every pathway at least once a year. You'll also notice that there is a key here to the amount of radiation in very approximate terms and relative terms that is produced by each modality. So if we go to the pathway itself, you'll see that this is all in the form of a flow chart. And the idea is that you step through the flow chart. When you get a patient, for example, with an adult patient with a headache, it asks you whether there are any red flag features. You'll notice also that if you go to a recommendation, so for example the CT of the head generally indicated, that the box there has those two radiation icons showing you that it's a moderate amount of radiation involved in that particular procedure. Most of the scenarios have images as well, so common pathologies. For example, this particular one has a CT scan which shows a glioblastoma multiforme. Now the imaging gallery is not complete, it's not comprehensive, but we are still expanding that as we speak. We can go to teaching points, which really just give you a few dot points, take-home messages, if you like, about that particular clinical scenario. There is also general information about imaging. So if I click on About Imaging, it takes us to the menu, which if I pick Common Procedures, talks about ultrasound, CT scan, MRI, etc. And if we just pick CT scan, it gives information in very generic terms about CT scanning. You'll notice also we have a little module for radiation training, and it's become apparent, particularly in the medical and the lay press recently, that there is an alarmist attitude to the use of ionising radiation, particularly from CT scans. So what we've actually done is we've actually produced, in conjunction with Professor Richard Fox at the University of Western Australia, a radiation training module, which I would encourage you to go through. It will only take about 20 minutes and will give you some background to the risk of ionising radiation as used in medical diagnosis. There are about 150 scenarios at the moment which cover all of the organ systems, everything from GI tract to, as you can see, paediatrics and breast imaging. I can't pretend that it's comprehensive. It's not going to actually deal with every single problem that will face the GP. On the other hand, I think in most cases the answer to the imaging problem can actually be found on the website. What I would like to actually appeal to you to do is to have a look, and if you think there are major gaps or in fact major errors, we would very much welcome any feedback, and we would be very grateful for any constructive suggestions that anybody might have.
And our thanks to Dr. Mendelson for his time. Now let's continue our discussion with Dr. Greenberger and Dr. Ward.
Rodney, let's move to some different types of X-rays. And I've heard that there is a considerable amount of controversy about cervical spine films if a fracture or instability is suspected, that they don't pick up much. And now I hear that lumbar films aren't all that great.
When you're looking at cervical and, well, cervical spine fractures or fractures of the spine in general, many fractures are missed, and occasionally they're very significant fractures. The pickup rate of fractures of cervical spines on plain radiographs is approximately just over 50%, versus CT where it's 98%. So,
okay, so we really can't be reassured by what we think might be a normal cervical spine X-ray done in our emergency department.
And I think if technically they're more limited as well, you know, your rate of pickup is going to be lower, and if you're not used to looking at it, lower. So I think if there is a significant history of spinal trauma, then it's worthwhile doing X-rays, because you may find an unstable fracture or slip, which would obviously make the situation far more of an emergency to deal with. But in general, you can't rely on the fact that the X-rays look normal.
Now you've got a lumbar spine here. What's wrong with this one?
Well, this patient was in a motor vehicle accident and had severe lumbar pain following it to the left of midline, and the patient came in looking for fractures. And the problem with looking at, for example, the lumbar spine is that you have all the bowel gas which is superimposed over the lumbar vertebrae and the posterior elements. And for example, there is a lucency running through there, but then you can say, well, maybe it goes off into the soft tissues and it's just a bit of bowel gas. You would probably pass that.
Yeah, because there's another one here and another one there.
And, you know, you would probably pass it. The importance of the history is that if you know that that's where they're sore, then you will look at those lines with a more jaundiced view of those lines, and you may well suggest that we do more. Or truthfully, perhaps we should have just started with CT, but certainly you'd want to go on and do a CT. So we did this in this patient, and you can see on the left side where we were concerned that there may have been something that, yes, at L2 there was a fracture of the transverse process. At L3 there's another fracture of the transverse process with mild displacement, and at L4 there's another undisplaced fracture.
We do get, in small country hospitals, the ability to do chest and peripheral limb, but I do sometimes think that peripheral limb X-rays and joint X-rays can miss quite a lot, particularly with ankle fractures or with ankle injuries. Well, this is a 20-year-old patient of mine who plays basketball, and he presented the day after the basketball match, and he'd trodden on somebody's foot and gone over. What would you expect to see on an X-ray, and what areas particularly would you look at with that kind of history?
X-rays of ankles can be quite difficult, and I've just brought up a normal lateral view of an ankle joint and a patient who's had an injury. On the normal X-ray of the ankle, what we're looking for is the soft tissues, particularly anterior to the ankle joint, and there's no significant fluid in that particular ankle joint. But in this patient, you can see there's quite a lot of soft tissue swelling just anterior to the ankle joint, and there's bulging of the joint anteriorly. If you measure this hemarthrosis, in the context would be a hemarthrosis, the larger it is, the more likely the patient is to have a fracture. So if it gets up to about 15 millimetres, probably 80 to 85% of patients will have a fracture somewhere. So even if you can't see it on the X-ray, you would probably be suspicious enough to go on and do a CT or an MRI or some other further imaging.
Mm-hmm.
In the context of your patient, it could be a talar fracture, or it could even be a Lisfranc type fracture, which
was what I was most worried about.
Which has occurred, and you know, if you saw bruising, I guess, on the sole of the foot around the the tarsal-metatarsal articulation line, then you'd be quite concerned about a Lisfranc type fracture, and they're very easily missed on X-rays. So when we're looking at the AP and oblique views of the ankle joint, what we're looking at is obviously to check the malleoli, looking at the talar dome and seeing if there's any osteochondral injuries going on. And this was the patient which had the hemarthrosis, and although it looks very normal, you can look at the talus and say it looks quite normal. When you go on and CT these patients, they'll often have quite significant fractures. So here there's a fracture which runs through the talus and extends to the talonavicular articulation. So very significant fractures are often present in the absence of any X-ray findings, but you would normally expect to see, if it is an ankle, a fracture related to the ankle joint, blood in the ankle joint in the acute setting. We often see fractures of the lateral malleolus, particularly distally where the collateral ligaments insert, and you may pull off a flake of bone with an anterior talofibular ligament type injury. But when you see a flake of bone that looks longitudinal like that, this is a really important fracture, not to dismiss as a little flake fracture. These longitudinal fractures which run parallel to the lateral malleolus relate to the retinaculum which holds down the perineal tendons, the peroneus longus and brevis tendons. And if you disrupt the retinaculum, what happens is that, and I'll just go down, so these are the peroneal tendons which normally lie in a groove behind the lateral malleolus, and there's a retinaculum which runs through there. What happens is that these tendons dislocate and move out laterally, and they shred. And then once they shred, then you often lose your normal plantar arch and you end up with a severe arthropathy involving the hindfoot. So it's really critical that these ones are managed as a significant injury and require orthopaedic review, because if it's just assumed, oh, it's a little flake, it's of no great consequence. It has got very substantial consequence. And
so that one would probably need screwing back?
Yes, and the retinaculum would have to be fixed or allowed to be united, and it would need an orthopaedic assessment for that. And then we touched on Lisfranc type fracture dislocations, and they're difficult for everybody involved. I think it's a difficult clinical diagnosis often to make, and it's a difficult radiologic diagnosis, and they're often missed.
So if we wrote suspect Lisfranc
then
injury, then your alarm bells go off as well.
Yes, and I think if you suspect there is a Lisfranc type injury, you would start with plain films, but you would probably move down to CT or MRI fairly quickly. And so often what you find, this is fairly normal, so when you look at the alignment at the base of the second metatarsal, it lines normally with the middle cuneiform.
Yeah.
The space between the medial cuneiform and the base of the second metatarsal is usually 2 millimetres or less, so it's fairly narrowed space. But when you disrupt the Lisfranc ligament, what happens is that there is a step-off which occurs, and you can see that the space is now widened beyond 2 millimetres, and that cortical margin doesn't align with the cortical margin of the cuneiform. And unlike the other metatarsals where there are ligaments which run transversely, there is no transverse ligament there, so it's a potential point of weakness. And it doesn't look that bad. This is another patient which is normal when they're non-weight bearing, but if we know that there's a question of a Lisfranc ligament, you get them to weight bear and you can see that it opens up. So when they actually stress that ligament, it's abnormal. So if we know that that is a concern, then we would do that. And so these are like little flakes which you may or may not see with Lisfranc fractures where they've been avulsed. And then the question is, well, does it really matter? Well, this is a case where it was missed in a young football player. And 6 months later,
it's like a disaster.
This is what occurs. So basically all the second to fifth metatarsals have all slid off laterally. He's got exuberant osteophytes and callus, and really that is beyond doing anything at this point. I guess he would end up with an arthrodesis or something like that at some point in time.
Arthrodesis and a large quantity of insoles and support structures.
So
he's going to be playing football again, is he?
So no. So although they look very minor and very insignificant, and they can be easily walked past by radiologists as well, they're really important not to miss. So if there's any concern, CT is the next step.
So Rodney, getting back to my basketballer, who could, I guess, have had any of these things, could you just talk me through what he actually did have?
Right. So on the radiographs, on the AP and oblique views, you can see there's quite a lot of soft tissue swelling adjacent to the lateral malleolus, and that we often associate with injury to the collateral ligaments. There's no evidence on this of fracture involving the malleoli or the nor is there an osteochondral injury involving the dome of the talus. When we go to the lateral, we see this finding again of quite a large hemarthrosis, and that would start to ring alarm bells that there is something more going on, because we haven't really seen a fracture in this case.
Rodney, I was quite worried about this patient, and he's you know, very fit and looking at a kind of a semi-professional career in basketball, so I elected to send him straight for an MRI scan, and fortuitously the MRI scan is arrow sign positive. Could you just tell me what I've got there?
Okay. So this is a sagittal reformatted view, or sagittal view I should say, on MR. There's a lot of fluid in the ankle joint, and that's consistent with the hemarthrosis, and that's consistent with those plain X-ray findings which we saw. Again, you can see that's an axial section, and again, there's quite a lot of fluid in the ankle joint.
Right, so this is the fluid here?
The fluid there, the white, yes. These are tendons which you're seeing. So these were the peroneal tendons, and these are the flexor tendons and the extensor tendons anteriorly. So you see them well on MR. And again, you can see when we alter the sequence, you can see changes within the talus, which would suggest that there's been extensive bone bruising associated with this injury.
Torn enough of the ligament to really bash the bones against each other and bleed.
Yes, and impact them and end up with bruising of the bone there. So he's got a fairly significant injury and would account for his presentation.
Knees are huge in country hospital presentations. Usually it's a hemarthrosis after playing football or netball as a very common cause of injury. If there is a hemarthrosis present, can you tell a great deal from a plain knee film?
I guess the only thing which you're going to see on a plain knee film is looking for a fracture. And if you have fracture, then obviously that's helpful. You don't see all fractures, but if one is present, then that's useful. Having said that, most hemarthroses probably relate in sporting injuries to injured menisci
or cruciate
ligaments, and you won't see anything more than a hemarthrosis potentially on an X-ray.
Now, if you decided to drain the blood, which most of us would probably do for the patient's comfort, and then we look at what kind of imaging is available, I've seen some ultrasound reports of ultrasound of knee that sort of talk about imaging the meniscus. Can you actually get a decent picture of a meniscus on the inside of a knee from an ultrasound?
No, it's not diagnostic by any stretch. Ultrasound is limited to looking for fluid in the joints, looking for Baker cysts, parameniscal cysts. So if you've got a parameniscal cyst, it would indicate that you have got probably a chronic tear of the meniscus. But the vast majority of tears of the menisci are occult on ultrasound. Sometimes you'll see extrusion of the meniscus. So you're looking for all the indirect signs of a meniscal tear. You actually can't see them directly. So if you're concerned the patient's got a meniscal injury, ultrasound is not the test to be ordering.
So you just go straight for MRI scanning.
Yes.
Is there a reason that they elect that over CT, or is it just to do with radiation dose?
MR's got a few positives over the CT arthrogram. One, the patient doesn't require an injection, so there's no risk of putting a needle into a joint and the complications which might be associated with that, or allergy to the contrast. There's no radiation, although radiation to a knee is probably inconsequential. But it also will allow you to have a look at the soft tissues around the knee joint, which the CT arthrogram doesn't see. So CT arthrogram is very good at looking at meniscal tears. It'll show you significant tears of the cruciate ligaments. It's quite good at looking at occult bony injury on CT of the knees, but it is more limited, and it's mostly done because of access to Medicare funding.
Now, patients do sometimes present with quite chronic pain that seems to be related to exercise, like usually their football training, or sometimes just their running. What does a stress fracture look like? And would we pick that up on a simple country plain X-ray?
Yes, the majority of stress fractures are probably not visible on X-ray. It's worthwhile doing, because if you find it, you will have a diagnosis. So what you're looking for is a band of sclerosis or a periosteal reaction at the site of pain. So if it's positive, it's very useful. If it's negative, it doesn't mean anything. So the majority of patients will need to go down the line of having an MRI or a isotope bone scan to confirm a stress fracture. CT is reasonable, but not as sensitive as either of those two tests.
So if you wanted a diagnosis in one test, you'd probably do your plain X-ray and then go straight for something quite sophisticated.
Yes.
The other thing that country doctors do sometimes use local imaging for is finding foreign bodies. Sometimes to extract them and sometimes just to see if they're there. What sort of things are radio-opaque and what's radiolucent?
Yes. Well, the only things which we'll find which are radio-opaque will be glass and metal. So they would be the commonest radio-opaque foreign bodies which you will see on an X-ray.
So little chunks of windscreen in somebody's
face. So windscreen will
orbit?
show. So if you, the problem with, for example, a facial injury is that unlike metal, glass isn't that opaque, so you would need to throw it clear of the bone. So if you did a tangential X-ray of the area of concern, then you probably would see it. But if it's just thrown over the skull vault or skull base, you won't in all likelihood see it. So you need to do a tangential X-ray. And once you go beyond metal and glass, you're into ultrasound territory in terms of looking for thorns and wooden splinters and so on.
Okay, and finally, abdomens. When is an abdominal X-ray useful?
Well, like all X-rays, there's limitations, and there's a lot of limitations with abdominal X-ray. So it's useful if you think the patient has a bowel obstruction and you're looking for dilated bowel and air fluid levels. So it's useful in that scenario. It's useful for looking for free gas in the abdomen. The only other time it may be useful would be in the context of looking for renal calculi. It is limited in terms of calculi, and you probably see at most 80% of calculi in the kidneys, and you probably see less once they leave the kidney.
So, Rodney, if we weren't to do an abdominal X-ray and we were deciding to do an ultrasound, what are the limitations of an abdominal ultrasound? I know I've got quite a number of patients who are quite significantly overweight. Yes.
The larger the patient, the less information you're likely to obtain. Having said that, I think ultrasound is still the way to start for a lot of things, depending on what you're looking for. So if you're looking for gallstones, you certainly want to start with ultrasound because it is the best available test. CT will often be negative with gallstones because many gallstones are non-opaque, so you can't see them. So, which is quite different to renal calculi, where essentially 100% of renal calculi are visible on CT. And ultrasound is quite unreliable when it comes to renal calculi. So for gallstones, you definitely want ultrasound. For renal calculi, you definitely want to go down the line of CT, assuming there's no other contraindications for doing it. So I would normally start with ultrasound. It's relatively inexpensive. There's no radiation involved for the patient. There's no contrast required for the patient. And whatever information you get is valuable. But if it's technically challenging, then you may have to go down the line of doing a CT, depending on what you're looking for.
Well, Rodney, we've covered an awful lot of things today. Thank you very much for joining us.
You're welcome.
And that's where we'll leave that discussion. Now, Rural Health West runs several regional and Perth-based CPD education workshops throughout the year. And one of the recent ones was a pilot workshop in Albany focusing on regional anaesthesia. It was called Ultrasound Guided Regional Anaesthesia, Acute Pain and Vascular Access. Professor Krishna Boddu, Director of Regional Anaesthesia, facilitated the workshop with a team of specialist anaesthetists from Royal Perth Hospital Department of Anaesthesia and Pain Medicine. He spoke with us about what's involved and the value you can get from attending one of these events.
So what you do is, in a simple word, pain is divided into two groups. One is called static pain and the other one is dynamic pain. So pain at rest is the static pain and dynamic pain is pain on movement. The opioids are the conventional method of pain control. However you give, still the pain on movement is not well controlled. So whereas the nerve blocks, they're so effective that pain on movement is also well controlled. So it's almost like a pain, the gift nobody wants. So pain is the one that is going to send you, patients go to the hospital. But once you know what is the reason for the pain, we don't want that symptom anymore. So pain is managed in rural health by GPs and the ED doctors. And what we see is the patients can significantly benefit with a wonderful pain control by using the nerve blocks, and it also limits the amount of narcotics or heavy opioids usage, and which is going to be a significant improvement, one to prevent use of the side effects of the opioids, which are not good, and then the nerve blocks is going to control the pain and movement significantly better than opioids. Rural Health West is conducting these courses in collaboration with Royal Perth Hospital And then this is the Royal Perth Hospital initiated this program of conducting regional anesthesia exclusively in a setup like this. And then we see that there is a significant value for teaching these techniques in the rural health for ED doctors and GP anesthetists and GPs. This is facilitated with Global Medicine Limited, not-for-profit organization, and that's going to be facilitating as well.
The best way is to go proximal.
Rural hospitals do have an ultrasound machine, so we use the ultrasound to visualize the nerves, where the nerves are, and then nerve stimulators are available very reasonable cost, and then the combination of this nerve stimulation and locating the nerves where the pain is coming from, and then take the needle close to that nerve and then deposit the local anesthetic, and that's going to control the pain. So the technology available is nerve stimulation. Maybe they might need to get special needles and then ultrasound machine. These are the three things required. So this is the nerve stimulator, and they're pretty reasonable cost, and then they're available. Several companies manufacture this nerve stimulator, and we put electrode on one side, and then these are simple needles that we use, and then this got a little special coating and special structure that is going to make that visible under ultrasound. And what we do is we connect this nerve stimulator to the needle, and then we put the nerve stimulator on a certain amount of current, and then we got a dial, and then we put that current on. Say for example, if I'm going to do a median nerve block for this gentleman here, so what we do is just you know where the median nerve is usually, and then we put the little gel, and then once you put the gel on, and then ultrasound machine is on, and then you take the of course, you are going to do everything under sterile conditions. This is only for demonstration purpose. So once you know where the median nerve is supposed to be, you can show you straight away there is the right bright structure with a honeycomb pattern, and that is the median nerve. And then what we do is we take the needle and then take it close to the nerve, and once we take the close to the nerve, then we can inject the local anesthetic around that nerve. So it's a simple technique to learn, and it's much safer if you know how to do the nerve blocks.
Corresponds to which on the screen?
The structure of the course is a one-day full hands-on part. So we start on the day, first day with a little breakfast or coffee, and then give a little orientation of didactics, and that too in the didactics we have interaction with the group who are participating. Then we take them to human volunteers and the simulators so that they get a hands-on practice on in small groups. Learning is a steep curve, and once you identify the nerves and you understand how to identify them, it's very simple to use the technique. The only thing is hand-eye coordination need to be mastered while conducting the nerve blocks. If any of you are interested in learning these modern techniques of conducting regional anesthesia, contact Rural Health West, and you will get value of conducting in a proper way and a safer way in your clinical practice.
And our thanks to Professor Boddu. The next workshop is scheduled to be delivered in October, and it'll be part of the Rural Health West Fremantle Conference. Visit the Professional Development section of the Rural Health West website for further details. And that's all the time we have for this program. Thanks to all our guests, Dr. Greenberger, Clinical Professor Mendelson and Professor Boddu for their time. Now remember, if you want to review this program or any of the others, they're available on the Rural Health West website, ruralhealthwest.com.au, and they go way back to 2009. We'll be back on the 6th of August with a program looking at eyes, eyelids and orbits. I'm Jerry Gannon. Thanks for joining us.